Low back pain in teenagers. This is quite different to the approach in low back pain in adults, where approximately only 5% have an actual specific pathology. In children, up to 73% can have a serious or specific pathology. So the approach has to be quite different. In low back pain in adults, we want to avoid imaging and don't always give a named diagnosis. And the approach is generally to reduce fear and encourage movement and return to valued activities. This is not the case in children or teenagers, as a lot do have a structural issue present. So who gets low back pain? It can happen to children who aren't involved in sports, but it's slightly more prevalent in those involved in sport. And especially throwing sports or sports that involve more intense training sessions like gymnasts, rowers and dancers. Those who have a high BMI are also more likely to experience back pain. So let's look at spondylolysis. The term represents a spectrum of bone stress injuries. This term, bone stress injuries, has replaced the old term of stress fracture. In teenagers, it is essentially abnormal load on healthy bone, as opposed to conditions in older populations like osteoporosis, where the quality of the bone is affected. That's abnormal bone. In adolescence, it's an immature skeleton. We see these bone stress injuries happen in these specific areas of the spine: pars interarticularis, the lamina, the pedicle, and the transverse processes. These injuries are seen overwhelmingly in the lumbar spine, the lower part of your spine. The pars area of the L5 vertebra is the most vulnerable due to its anatomy. A lot of shearing force happens at this area. As you go through a growth spurt, the pars itself elongates and thins, just as the bones in your legs do. This reduces the bone mass of the pars, so it's more vulnerable during this time. The pars itself doesn't fully mature until the age 25, so this diagnosis has to be considered for people up until their mid-20s. Repetitive hyperextension movements, so where you're leaning back a lot, can cause inflammation around the discs and the facet joints. The spinous processes can also be affected due to the ongoing extreme ranges that athletes like gymnasts explore in their daily training. So these bony parts of the spine are essentially rubbing together and causing bone bruising in the spine. These people's pain will be aggravated by bending backwards and sideways. These people will experience less back pain when resting and sitting. This is very different to the cohort of non-specific back pain sufferers who will experience pain sitting and resting, and their symptoms are eased by movement. However, if a teenager makes their back extremely sore, all of these movements can irritate it. In flexion-based sports like rowing, cycling, and positions in rugby like playing in the pack, the prevalence of back pain in these intensity flexion-based sports is extremely high. It will be far more unlikely to not experience some episodes of back pain. The type of issue can be very frustrating for teenagers, as when it's sore, it's aggravated by flexion, so any prolonged sitting can cause pain. When people experience pain, they can have altered muscle recruitment patterns, and pain can spread to the glutes, hips, and down the legs into their hamstrings. Just because they are teenagers, it doesn't protect them from illness, so a thorough screening for red flags needs to be conducted the same as it would be for adults. Red flags will be constant, unremitting pain, night pain, pain affecting sleep, walking, very interruptive pain, associated with, say, if you've got nausea or headaches, fever, fatigue, if there's weight loss, reduced appetite, sweating, incontinence, a change in the child's behavior, they become irritable, quiet, fatigued. Children don't always report pain the same way that adults do. Parents often have a feeling that they're just not right. A regression in motor milestones, so a drop in performance, they're unable to do things that they were able to do or that they should be able to do. Back pain in anyone under the age of 6, a GP will refer out. Red flags warrant an immediate visit to the GP as opposed to a physiotherapist being the first stop. So let's look at Scheuermann's disease. This causes low back pain because of stiffness in the mid-back. It is a pathology that affects the growth plates, where a wedging of at least 3 consecutive vertebrae occurs. This is more common in children aged 13 to 16 and more common in boys than girls. This is linked to a rapid growth spurt in the teenage years when the spine grows. You will see an increase in the curve of the spine. It presents as intermittent low back pain. It can be low back pain at rest. They start to get a reduction in thoracic extension, so the ability to do this, and rotation, so they look and they feel and they move stiffer. With this stiffness in the mid-back, you can sometimes see the body react around this stiff area with a more forward head position and the development of spondylosis in the low back because of the excessive shearing forces. This diagnosis is confirmed by an MRI scan. Another common one is idiopathic scoliosis. This is an abnormal lateral curve of the spine that can cause back pain. This can worsen with growth, so it's one that needs to be tracked over several months. Parents can take a photo of the child's bare back and compare a profile over months. A curve of over 20 degrees warrants orthopedic specialist who has expertise in scoliosis. Juvenile arthritis is also a diagnosis that needs to be ruled out. Family history of arthritis, morning stiffness affecting other joints, etc. The GP will arrange blood tests and onward referral in this case. Now let's look at bone stress injuries. Bone stress injuries are a spectrum and they aren't all stress fractures. Our bones are clever. In response to any form of load, bones have microtrauma and our bodies produce more bone cells. So our bodies produce more bone in the areas where we need more bone. This is a normal adaptive process. Our bodies need load to stimulate this process, but when there is a spike in load or our bodies can't cope with that load, we can sometimes see injury. So we get an injury when the load increases beyond the capacity of our tissues or when our capacity is reduced. Here's an example of how this might happen. You get a spike in load and an increase in newborn bone formation. A new bone isn't strong enough yet. The injury risk is 1 to 4 weeks after the spike. Then you can develop a bone stress injury. So it's the new bone that starts to break down, causing bone bruising or a fracture. So it doesn't present in a way where they do an extra amount of training or activity and they experience pain that next day. There can be a delay. The new bone is immature and you need more repeated load to cause the injury. So you can see a delay of anything between 1 to 4 weeks. This bone stress injury is a continuum from bone bruising to pre-spondylolysis. Resting here might allow symptoms to settle and the bone to adapt. This can progress to a full spondylolisthesis. A spondylolisthesis is a forward translation of one vertebra over the one beneath it. These are divided into grade 1 to 4. Grade 1 is a 25% slip, grade 2 a 50% slip, grade 3 a 75% slip, and grade 4 a 100% slip. These injuries are more common in sports like gymnastics where athletes take themselves to extreme range repeatedly with a high training frequency. The spondylolisthesis injuries can result in bracing and prolonged time away from sport. That could be a minimum of up to 6 months. Let's look at the factors involved in teenagers picking up bone stress injuries. So key risk factors: the load they aren't prepared for. It's a spike in workload, a lack of sleep, nutrition, growth spurt, stress, a lack of strength, too little recovery in between sessions. There is a misconception that teenagers are doing too much training. It's not the case, and teenagers who have a high chronic workload have caused their bodies to adapt and have 5 times fewer injuries if their bodies are given enough time to adapt. Training errors have a major bearing in injuries, and here are some of the common pitfalls. Low absolute loads, relatively new to a sport, or they're just not that fit. Sudden, acute, excessive spikes in load, so not training at all and then training 5 times a week for 3 weeks. A large week-to-week changes in load. Too little recovery. The intensity, not just how much we do it, but how hard we are training. So doing too little for too long, maybe in the off season, not doing enough and then resuming training with high loads in the first few weeks can mean we get injured because we go above our current capacity. We've done too much too soon. This causes stiffness and some pain, so we do nothing again for a week or two. So now we drop back to doing no activity and are doing too little again before we resume team activity at high intensities. This is the pain, rest, weakness spiral, followed by spikes in load, and it's a roller coaster of doing too little, then doing too much. This is very frustrating for athletes and coaches. Now it's not always as straightforward as this, as people train at varying intensities. The well-intended advice from parents to try your best can mean some children train at 10 out of 10 intensity every single session. This isn't done by elite athletes, but teenagers might be in a position where they're trying to be selected for a team, or they feel pressure internally or externally to go harder or do more. So they might be going too hard as opposed to doing too much. Using the RPE scale can be helpful when trying to assess this. The RPE scale is just rate of perceived exertion, so not all training sessions should be an 8 or 9 or 10 out of 10 intensity. Other things that can cause spikes in injuries are the seasonal nature of sports, or do sports or team activities overlap? Are they training with the club Tuesday and Thursday and Saturday, and then with the school or the county team on a Monday and a Wednesday? Has school activity been added in? So factors like how much training or activity per day, how many hours per week, how hard they work in these sessions, and the repetition of hyperextension positions all contributes to these injuries. Assessing whether a teenager is doing too much and whether the volume and intensity is right for them can be subjective, and because of multiple sports and multiple teams, as well as teenagers potentially having no previous experience of pain or injury, and the social impact of missing out on their time playing with teammates and friends, quantifying load and assessing whether it's too much is not always straightforward. We often have to look at the bigger picture and not just focus on the pain site. These are the types of questions that can provide helpful information. So pain, is it just low back pain, or do they have pain in other areas too? Fatigue, are they getting enough good quality sleep and do they feel refreshed in the morning? Wellness, are they run down, getting more sore throats, etc.? Stress levels, look at mood swings, loss of motivation. Performance, has there been a drop in performance? Nutritional factors have to be considered in bone stress injuries. Do they have the energy and appropriate food and protein intake to be able to cope with the energy demands of their sport and rehab? Asking these types of questions can help us to make more informed decisions and ensure better short and long-term outcomes for teenagers suffering with back pain. So getting teenagers back to their sport after back pain. The best starting point is to think of the end goal. What do they need to be able to do? What are the demands of their sport from a strength, power, endurance, conditioning point of view? A successful rehab plan will prepare them for these demands while avoiding recurrences and educating both teenager, parent and coach on what to expect in order to avoid seeing them in the physio room again in a few weeks or a few months' time. The aim should be to get them safely back to their sport and to keep them injury-free and training going forward. The starting point is often 2 weeks of complete rest. If they are pain-free in their daily activities after 2 weeks, you should begin a rehab program which is guided by symptoms. Gradually increase the intensity of rehab if symptoms allow until they successfully and confidently return to their sport. If pain persists after 2 weeks of complete rest, an MRI scan can be beneficial, and an MRI confirmed bone stress injury will need 3 to 6 months of a rehab program. The general phases of recovery are: protect, first 2 weeks. This involves modification of activities, no running, jumping, and avoiding all pain-provoking activities. This includes messing with friends or siblings on the trampoline or lying for hours on their tummies playing video games. They may be able to go on a stationary bike, but that's usually about it. It's practically complete rest other than that at this stage. This is a time they can better understand why this happened and what they're going to do to overcome it and prevent a recurrence in the future. Very frustrating, but first 2 weeks is complete rest. The best approach is to involve the teenager in the discussion around the recovery process. Make sure the pain makes sense to them. Giving them confidence and competence to self-manage, address their fears and concerns is often crucial. Teenagers can be slow to open up and express their feelings, and it's vitally important to try to understand the impact of the symptoms on the child. The repair phase, 2 to 4 weeks. It could be up to 8 weeks depending on the severity of the pain and the injury. In this phase, they can be more proactive and address some of the biomechanical factors contributing to this issue. Trunk control exercises, isolated lower limb strengthening exercises, as well as balance exercises can be commenced with walking and the bike as their only cardio exercise at this time. Moving on from one phase to the next is dictated by them being pain-free and having good control over their current exercises. Start to move. In this phase, they can move into gym strengthening exercises and do a lot more movement. This is the phase where they will work on improving specific qualities like strength, power, and conditioning. The start to train. The reintroduction to training phase can be where people mess up in that they return to doing too much training too soon. This can be out of excitement and happiness to be back doing what they enjoy doing, but it's important to ease into this phase especially. For example, doing day on, day off, allowing your body to recover from the training and using the day off to monitor symptoms and energy levels. They need to be fully back training for several weeks before they return to playing. And then you've got your return to play phase. The trickiest part is that return to training phase, in my opinion. So in summary, The most common cause of low back pain in youth athletes is a lumbar bone stress injury, but not all low back pain is a bone stress injury. Bone stress injuries are a continuum from bone bruising to a stress fracture. They happen when activity exceeds the capacity of the bone and are most common in hyperextension-based sports like gymnastics and swimming. There are several causes contributing to this, and the teenager, the parent and the coach need to understand this condition well in order to fully recover and prevent reoccurrences. If you have any questions on this or would like some help, please feel free to comment below or reach out.